Hi everyone, welcome back to your channel I Love Pharmacology. In this session, let us understand the drugs which are available for the treatment of glaucoma, that is, anti-glaucoma drugs. So, at the end of this session, you should be able to understand the key features and the clinical findings if a person is suffering from glaucoma, and also how to diagnose the glaucoma, and also the treatment available for glaucoma. At the end of this session, one must be able to answer these questions. There is a question to answer. Which is the drug of choice for primary open angle glaucoma? First line drug available for the treatment of glaucoma. Which is the beta blocker which is safe in glaucoma associated with bronchial asthma patient? Which is the specific side effect of latanoprost? Which is the specific side effect of brimonidine? Which is the special drug delivery system available for treatment of glaucoma? Which are the drugs which increases uveoscleral outflow? Which are the drugs which can increase the trabecular outflow, and the mechanism of action of the nitarsudil. So coming to the glaucoma, glaucoma is characterized by raised intraocular pressure, which in turn leads to damage to the optic nerve as well as disc associated with retinal damage, which left untreated will lead to irreversible blindness. To understand the pathophysiology of glaucoma, one needs to understand how aqueous humor is produced. Aqueous humor is produced from the ciliary body from the filtration of the ciliary blood vessels, which are having the alpha 1 and the beta 2 receptors. And what is the cause for glaucoma? The cause will be either due to increased aqueous humor production or due to blockage or obstruction to the aqueous humor drainage. So, to understand the drugs targeting the glaucoma, let's understand the normal aqueous humor flow. So, once the aqueous humor is produced from the ciliary epithelium of the ciliary body in the posterior chamber, it passes through the iris and the lens, followed by it enters into the anterior chamber through the pupil, and from the anterior chamber through the trabecular meshwork or the canal of Shelb, it will be drained out. So, canal of Shelb is the intersection of the cornea and the iris, which is also known as the ocular angle. So, let's understand the what are the types of glaucoma available. We have three types of glaucoma. One is the primary, which, where the cause is unknown, and the secondary glaucoma. It is due to aphakic glaucoma following cataract extraction, and the congenital glaucoma, where the surgery is preferred. So based on the angle of the anterior chamber, primary glaucoma can be classified into narrow angle glaucoma and the wide angle glaucoma. Narrow angle glaucoma is also known as acute congestive glaucoma, and it is also called by other names such as closed angle glaucoma or the angle closure glaucoma. On the other hand, we have a wide angle glaucoma, which is also called as chronic simple glaucoma or open angle glaucoma. Based on the angle, they have classified into narrow angle and the wide angle. Based on which angle, that is the ocular angle. So coming to the narrow angle glaucoma, which is a medical emergency, because whenever the ocular angle is narrowed due to the pressure from the posterior chamber, the iris is pushed forward, thereby it closes the ocular angle, thereby it blocks the drainage of the aqueous humor. Where iris physically blocks the aqueous drainage, symptoms will be red eye, headache, nausea, vomiting, and sweating. And in case of narrow angle glaucoma treatment, which is a medical emergency, drugs can be used to control the acute attack, like astazolamide can be used, but the definitive treatment will be the surgical management, that is the partial iridectomy. On the other hand, we have a wide angle glaucoma treatment where the ocular angle remains wide, but it is mainly due to the trabecular meshwork defectiveness, where trabecular meshwork loses patency due to progressive degeneration, thereby the outflow is obstructed, although the angle remains wide. Wide angle glaucoma is usually gradual in onset and insidious in onset. And here we require a continuous drug therapy, and surgical intervention is not that useful. So, based on the cause of glaucoma, you need to treat the glaucoma. The cause was either due to increased aqueous production and the decreased drainage. So, you need to find the drugs which can decrease the aqueous humor production or which can increase the drainage. So, the drugs which can decrease the aqueous humor production can be remembered in the form of mnemonic ABC. So, before that, let us understand the receptors which are available in the eye. So, alpha 1, which is present in the ciliary blood vessels, when it is stimulated, it causes vasoconstriction, thereby decreases the blood flow. Since the aqueous humor is formed from the filtrate of the ciliary blood vessels, if the blood flow is decreased, what happens to the aqueous humor production? Aqueous humor production is decreased. Therefore, we can use alpha 1 agonist here to treat glaucoma. Alpha 1 agonist will decrease the aqueous humor production. The example is the dipivefrin. On the other hand, we also have a beta 2 receptors on the ciliary blood vessels. Activation of beta 2 receptors will cause vasodilation, which increases the blood flow. So, increase the blood flow means there is an increased production of the aqueous humor. So, here in case of glaucoma, you need to decrease the aqueous production. So, you need to block the activity of the beta 2 so that you can decrease the aqueous humor production. So, we use alpha 1 agonist as well as the beta 2 blockers for the reduction of the aqueous humor production. On the other hand, we also have a carbonic anhydrase enzyme where activity of carbonic anhydrase enzyme on the bicarbonate will lead to breakdown of bicarbonate into water and the carbon dioxide. This water will going to increase the aqueous humor. So here to decrease the aqueous humor, one needs to inhibit the activity of the carbonic anhydrase enzyme. So the example is the brinzolamide. So these are the drugs which can decrease the aqueous humor production, that is the alpha 1 agonist, beta 2 blockers, and the carbonic anhydrase inhibitors. On the other hand, to increase the aqueous humor drainage, we have a two kinds of outflow system, that is a trabecular outflow which controls the 90% of the aqueous humor drainage. On the other hand, we have a uveoscleral outflow which controls the 10% of the aqueous drainage. So to increase the trabecular outflow, we have a meiotics like the pilocarpine, which stimulates the M3 receptor which is present on the circular muscle fibers. Thereby it causes meiosis. Thereby the crowding near the ocular angle will be prevented, thereby making a way for the drainage of the aqueous humor through the trabecular outflow. And also we can use alpha 1 agonist. Alpha 1 agonist will cause vasoconstriction, thereby decreases blood flow, and in turn it can increase the trabecular outflow. On the other hand, we have a uveoscleral outflow. Here, the main drug available is the prostaglandin analogs like latanoprost. And also, alpha 1 as well as alpha 2 agonists have shown to increase the uveoscleral outflow. Let us talk about the drug of choice which is available. The drug of choice for the primary open angle glaucoma is the latanoprost, which is a prostaglandin F2 alpha analog. And in the case of closed angle glaucoma, we prefer a pilocarpine, which is a meiotic. And also in case of acute congestive glaucoma, before the surgery, for the acute reduction of the pressure, you can use astazolamide. Bitoxolol is a drug which is having a beta 2 blocking activity, which is cardioselective, which blocks beta 1 receptor only, and it has got additional mechanism, that is it has got optic disc perfusion as well as neuroprotection, and they are preferred in the glaucoma associated with asthma individuals. Cardiolol is a one more beta blocker. It is preferred if the individual has got hyperlipidemia. There is one more drug which has got neuroprotection, which is a alpha agonist, that is the brimonidine. So do not confuse with the brimonidine and the brinzolamide. Brimonidine is a alpha 2 agonist, whereas brinzolamide is a carbonic anhydrase inhibitors. Let's talk about the adverse effects. So meiotics can be remembered in the form of last two words, that is CS. It causes cataract and the spasm of accommodation as well as stenosis of the nasolacrimal duct. Whereas the prostaglandin F2 alpha, you can remember it as PGF. It causes pigmentation of the iris, which is called as the heterochromia iridis, growth of the eyelashes, which is called as hypertrichosis, fluid in the macula, that is macular edema. It can be associated with uveitis, dry sandy eye, and the orbital fat atrophy. On the other hand, epinephrine, uh, on metabolism, it produces adrenochrome, which causes pigmentation of the conjunctiva. So, pigmentation of the iris is caused by prostaglandin analogs, whereas pigmentation of the conjunctiva is caused by epinephrine. So, apraclonidine causes lid retraction and the dry mouth as well as sedation. So, brimonidine will depress the respiratory system, thereby it causes apnea. Therefore, it is contraindicated in individuals below 2 years. Whereas the beta blocker has got side effects like allergic blepharoconjunctivitis, corneal hypoesthesia, vision blurring, etc. Carbonic anhydrase inhibitors can cause bitter taste and the corneal edema. So there are trials which are done for the treatment of primary open angle glaucoma. Just you need to remember the names. We have Apollo trial, Luna trial, and the Jupiter trial were done for particularly for checking the effectiveness of the drug in primary open angle glaucoma. So one speciality of clonidine is they increases the trabecular outflow, whereas we can use clonidine congeners like brimonidine, apraclonidine, and also by acting on the alpha 2 presynaptically it decreases the neurotransmitter release, thereby in turn it can decrease the intraocular tension. On the postsynaptic sites, alpha 2 activation can cause vasoconstriction in the anterior segment of blood vessels, thereby decrease the blood flow to the ciliary body, thereby decrease the aqueous humor production. We have a newer drug that is latanoprost bunodone, which is a prostaglandin F2 alpha analog, which is a combination of the latanoprost acid and the butanediol mononitrate. This butanediol mononitrate has got additional nitric oxide donating property, and this latanoprost acid will increase the evascular outflow, whereas the butanediol mononitrate will increase trabecular outflow. And the side effects like pigmentation, growth of eyelashes, fluid in the macula is very less with latanoprostin bunod when compared to the latanoprost. We have a newer drug that is nitarsudil, which is a Rho kinase inhibitor. It's a potent Rho associated kinase inhibitor. It is also called as ROCK inhibitor, and also it is a norepinephrine transport inhibitor, ROCK inhibitor, and then NET inhibitor. Especially these are useful in the normotensive glaucoma or the steroid induced glaucoma. So let us talk a brief about the ROCK, that is Rho associated kinase, which is required for assembly of the actin fibers and focal adhesion within the trabecular meshwork. The inhibition of the ROCK will cause relaxation of the trabecular meshwork, thereby it increases the aqueous humor outflow. The inhibition of the norepinephrine transporter system will increase the adrenergic transmission, thereby it decreases the aqueous humor production. And one must remember the adverse effects of the nitarsudil. This can cause conjunctival hyperemia because of the vasodilation of the conjunctival blood vessels. It can cause corneal verticillata, which is a vortex keratopathy. It can cause corneal deposits. It will have a faint golden brown whorl pattern. They can cause corneal staining and subconjunctival hemorrhage. The three things we should remember about the side effect is which is the drug which can cause pigmentation of the iris. It is your prostaglandin analog, that is latanoprost, which is the drug which can cause pigmentation of the conjunctiva, that is your epinephrine, which is the drug which can cause the pigmentation or discoloration of the cornea, it is your nitarsudil. So coming to the summary, so one must understand the drugs which are decreasing the aqueous humor can be remembered as ABC. We have a alpha 1 agonist like depivefrin, etc. We have a alpha 2 agonist like apraclonidine and brimonidine. Basically, it stimulates the GI coupled G protein coupled receptors, which decreases cyclic AMP, thereby decreases aqueous humor. On the other hand, we have a beta 2 blockers preferred, that is the timolol, livobinolol, cortiolol, metoprolol, and bitoxolol. Bitoxolol is a cardioselective agent preferred in asthma. These beta blocker will block GS type of G protein coupled receptor, thereby decreases cyclic AMP and decrease the aqueous humor production. Whereas the carbonic anhydrase inhibitors, we have astazolamide, which can be given orally as well as IV, and topically we have a brinzolamide and dorzolamide. The drugs which can increase the aqueous humor drainage are the miotics like pilocarpine, physostigmine, and ichthyophate, and alpha-1 agonists like depivefrin. Use of physostigmine and ichthyophate has been declined because of the side effects such as cataract and the eye pain. The UV scleral outflow will be increased by prostaglandin analogs like prostaglandin F2 alpha. Example is the latanoprost, bemetoprost, travoprost, uniproston, and the tefloprost. We have alpha 1 and alpha 2 agonist, which is a congener of the clonidine, that is apraclonidine and the brimonidine. The answer that needs to be known at the end of this session for the question which was posed in the initial slide is the drug of choice for primary open angle glaucoma is latanoprost. The first line drug in the glaucoma is latanoprost, which is a prostaglandin F2 alpha agonist. Beta blocker, which is safe in glaucoma associated bronchial asthma, is betoxolol because it's a cardioselective beta blocker. So the side effect of latanoprost is PGF, that is pigmentation of the iris, growth of eyelash and the macula fluid. The side effect of brimonidine is apnea and contraindicated in less than 2 years of individuals. A special drug delivery system which is used for treatment of glaucoma, which is a miotic, is the pilocarpine. It is available in the form of Accusert, which will act for 7 days. And the drug increasing UV scleral outflow is the prostaglandin, a 2 alpha agonist as well as alpha 2 agonist. And drug which is increasing the trabecular outflow is the miotics, that is pilocarpine, and the alpha 1 agonist like the apraclonidine and the brimonidine. And nitarsudil mechanism of action is it is a prokinase inhibitor as well as it inhibits the norepinephrine uptake transport system. Thank you.